Hi, everyone. I'm Mary Ann Joyce. I'm the physician liaison for OHC, and thank you for joining us for our November lunchtime learning presentation. We chose to discuss lung cancer because this month, November, is Lung Cancer Prevention Month. And Dr. Anu Paul will be doing the presentation. She's one of our board-certified medical oncologists and hematologists. She's also boarded in hospice and palliative care. And her interests include breast and thoracic oncology. And she has 3 children that keep her busy. Go ahead and take it away, Dr. Paul. Thank you so much.
Thank you, Mary Ann, for the introduction. So today we will be talking about understanding the types, risk factors, and treatment options for lung cancer. Next slide, please. So more than 200,000 cases of lung cancer are diagnosed annually, and roughly 20% of all cancer death is attributed to lung cancer. And one of the reasons there is a high incidence of lung cancer related death is because it's usually diagnosed at an advanced stage. Over 60% of lung cancer are diagnosed at advanced stage and 50% are at stage 4 at presentation. Now, when it comes to lung cancer related death, it's one of the leading cause of cancer related death in United States and also around the world. Almost as many Americans die of lung cancer every year as die of prostate, breast, and colon cancer combined. And when you look at the lung cancer rates in Ohio, it has a higher incidence when compared to the rest of the US, 65 per 100,000 versus 53 per 100,000 in US. And roughly 9,000 new lung cases are diagnosed. And that comes up, next after breast cancer. And even in Ohio, too, lung cancer is the leading cause of cancer-related death. In 2022, 6,000 deaths were attributed to lung cancer. Next slide, please. So this picture shows the lung cancer incidence when compared to other cancers. In men, the most common cancer is prostate cancer, and then comes lung cancer. And in women, breast cancer is the most common cancer, and lung cancer is the second one. But when it comes to cancer-related death, lung cancer is the most common cause of cancer-related death in both men and women. Next slide. When it comes to risk factors, as we all know, cigarette smoking is the highest risk factor. 85% of all lung cancer occurs in smokers. Smoking has a 15 to 30-fold higher risk. The other causes in non-smokers, I would say secondhand smoke, 20 to 30% increased risk of lung cancer. Then there is radon exposure. And interestingly, I found that radon in Ohio is actually higher than the rest of the US. Occupational exposure is another reason for lung cancer risk in non-smokers, and so is air pollution. When it comes to screening, annual low-dose CT screen is recommended for people who are at high risk, which is defined as 20-pack year smoking history, and those who are between the ages of 50 to 80, who are currently smoking or quit within the last 15 years. When it comes to cancer screening, we also look at something called number needed to treat, which means our number needed. So how many people we have to screen in order to prevent one cancer-related death. In lung cancer, it's 130 high-risk people screened to prevent one lung cancer death, which with a relative mortality reduction of 18 to 21%. Now the graph on the right side, you can see If you go back like 100 years, cigarette smoking started around the time of Great Depression. And then, after World War II, there was a peak. And then somewhere closer to like 1960s, first Surgeon General's report came with a risk of cancer associated with smoking. And afterwards, the smoking has or the cigarette consumption has continued to decline. There was also a federal cigarette tax increase of 42% somewhere in 2000. So if you look at the incidence of lung cancer related to smoking, it's on the decline. But at the same time, when you look at certain ethnicities and also non-smokers, unfortunately, it's rising. Next slide, please. There are two types of lung cancer, small cell lung cancer and non-small cell lung cancer. So small cell lung cancer, it's called small cell based on how it appears under the microscope when after the staining and everything. Small cell lung cancer comprises 15% of all lung cancer. So it's not that common, but it's strongly associated with smoking. Non-small cell lung cancer is the most common kind, and it's again divided into adenocarcinoma, squamous cell, which are most common, non-small cell subtypes, followed by large cell carcinoma, and then there are some other non-specific variants. Paraneoplastic effect. This is a unique phenomenon seen with certain lung cancers where our body has an abnormal response to cancer cells and produces certain hormones which targets healthy tissues. In small cell lung cancer, low sodium because of SIADH is common. And SVC syndrome is an emergency. It's superior vena cava obstruction, where patients can present with significant shortness of breath, facial swelling, edema, redness. And this is one of the emergencies where we may have to contact radiation oncology to start treatment. Squamous cell carcinoma can sometimes present with high calcium because of PTH-related peptide. The other syndromes mentioned are not very common, like Cushing syndrome, carcinoid. Eaton-Lambert is something similar to myasthenia gravis, but those are some of the other paraneoplastic syndromes. Small cell lung cancer accounts for roughly 15% of all lung cancer, and it's very strongly associated with smoking. 95% of cases occur in smokers. And unfortunately, in small cell, most of the time we diagnosed at an advanced stage. That's because small cell lung cancer has a tendency for fast growth, early and widespread metastasis. And it has a poor prognosis. 5-year survival rate in extensive stage small cell is only 7%. Small cell lung cancer is classified to two stages, limited stage and extensive stage. So limited stage is when the cancer is confined to one hemithorax and regional nodes amenable to single radiation field. And limited stage sometimes can present with rapidly progressive symptoms like cough, dyspnea, chest pain, weight loss, significant respiratory distress, requiring sometimes intubation. But small cell is also very responsive to chemotherapy. So this is one of the cancers where we might consider giving inpatient chemotherapy if the symptoms are related to the small cell lung cancer, because it can respond very quickly to chemo. But the unfortunate thing is it has a tendency to come back pretty quickly. Paraneoplastic syndromes, like I mentioned, are also very common. Okay, next slide. So stage 1 small cell lung cancer, it's extremely rare to find it at stage 1 where There is no evidence of lymph node involvement, just a nodule. But in the rare case, if we do find it, surgical resection, usually lobectomy with mediastinal lymph node dissection is the preferred approach, followed by chemotherapy with cisplatin and etoposide. If the patient is not a surgical candidate because of poor lung capacity, then usually stereotactic, or for whatever reason, then stereotactic ablative radiation therapy, which is directed just to the lung nodule, followed by chemotherapy, is an option. 2-year survival rate in the extremely early stage, so stage 1 with no lymph node involvement, small cell, is around 65%. Most of the time in limited stage small cell, by the time we diagnose, it's unresectable. There is nodal involvement, so surgery or stereotactic radiation is not possible. So we give concurrent chemoradiation with cisplatin etoposide. It has a very high response rate, 70 to 90%. But when you look at the median overall survival, it used to be only 25 to 30 months, because there is a high chance for the cancer coming back. And nowadays we use consolidation immunotherapy. So after the chemoradiation is done, patients get immunotherapy with durvalumab, and that has improved median survival to up to 56 months. And small cell lung cancer has a very high tendency to go to brain. So usually in patients with a limited stage and those who achieve a complete or partial response, we give prophylactic brain radiation. Extensive stage small cell lung cancer, the definition is the disease cannot be encompassed within a single tolerable radiation field, either because of distant metastasis or because of malignant effusions. And the first line treatment in extensive stage usually is platinum-based chemo, cisplatin or carboplatin with etoposide combined with immunotherapy, followed by maintenance immunotherapy. Standard dosing is usually 4 to 6 cycles of chemoimmunotherapy and followed by immunotherapy alone. And in some cases where patients have a low bulk residual thoracic disease, we give thoracic radiation after the initial chemoimmunotherapy. And in patients who had a good response to initial treatment, we consider prophylactic cranial radiation. And in some cases, we do MRI surveillance. But even with all of this, unfortunately, the median overall survival in extensive small stage is still very poor, 12 to 13 months with chemoimmunotherapy. And the 5-year survival rate, I think this is an error in the slide, but it's usually like 5 to 7% or so. So it's not good. Non-small cell lung cancer, like I mentioned earlier, it's divided into adenocarcinoma, squamous carcinoma, which are more common. And then there is adenosquamous, large cell, and some rare types. When it comes to treatment of non-small cell lung cancer, if it's early stage, let's say stage 1, where the cancer is just limited to a lung nodule, and there is no lymph node involvement, then usually the preferred approach is surgery. But if patient is not a candidate for surgery, either because of COPD or some other risk factors, then we go for SBRT, which is stereotactic ablative radiotherapy. When it comes to stage 2 lung cancer, where there is hilar lymph node involvement and lung nodule, we usually prefer the neoadjuvant chemoimmunotherapy, followed by surgery. And in cases where it's not, surgery is not an option, probably radiation. When it comes to stage 3A, if surgery is possible, we still go for neoadjuvant chemoimmunotherapy followed by surgery. If that's not an option, then we usually give chemo and radiation together, followed by immunotherapy. And in stage 3B and 3C, standard of care is usually chemoradiation followed by immunotherapy. And in some cases, if patients have targetable mutations, for example, EGFR, ALK mutations, or if they are strongly PD-L1 positive, then after the surgery, we do, or like the definitive treatment, we do give targeted therapy, and that can improve overall survival. This is an older slide, and things have changed a little bit, even though it's not as good as what we want. So localized disease, 5-year survival rate used to be around 55%. Now it's probably like 65% or so. Regional stage, the 5-year survival rate, 28%, probably nowadays closer to 40. And patients with distant mets used to be 4%. This is from 2013. Nowadays it's like 10 to 12% or so. So it has improved, but still not a lot better than before. When it comes to stage 4 non-small cell lung cancer, a lot of changes has happened in the last 10 years. The prognosis, like I mentioned, it has changed, especially for people with targeted therapy. For people with certain mutations like EGFR, ALK, ROS1, there are targeted therapy that we can give, which can improve overall survival significantly. Historically, 5-year survival rate used to be around 12%, but in those patients with some of these mutations, we are looking at 5-year survival rate 20 to 40%, in some cases even higher than that. In patients without any actionable mutations, we usually give a combination of chemo immunotherapy. And there is also a role for anti-angiogenic agents like Avastin in non-squamous histology. Clinical trial enrollment is also highly encouraged. When it comes to second line and subsequent therapy, the response rate is not that great, and our options are kind of limited, and also involving palliative care early on. Because as I mentioned before, the overall survival in general is still not very good when it comes to stage 4 lung cancer. Prognosis varies by stage, histology, and molecular markers. So for stage 1, 5-year survival rate, 55 to 67%, stage 2 to 3, 27 to 45%, stage 4, 12%. But in patients with certain molecular markers, the survival can be much longer. For example, in EGFR positive patients, 5-year survival is like 34%. ALK positive, it could be like 56 to 65. So the 5-year survival rate has improved in certain patients with targetable mutations. It's a lot better, but these mutations are not very common. So for the majority of lung cancer patients, the median overall survival is roughly 16 to 22 months with chemoimmunotherapy. With that, I end my presentation. Any questions?
Feel free to come off mute if you have any questions. Okay, it doesn't seem like we have any questions. Thank you all so much for attending, and I will, this has been recorded, and so I will send out the recording. Thank you again, and we'll see you in December. Hope you all have a nice Thanksgiving. Bye.
Bye.
Hi, everyone. I'm Mary Ann Joyce. I'm the physician liaison for OHC